Thank you for joining us for 4 years of living with COVID. What have we learned? This session is sponsored by ACP's COVID-19 Management Program and presented by Dr. Aaron Glatt. Dr. Glatt is Chairman of Medicine and the Tiori Endowed Chief of Infectious Diseases, Hospital Epidemiologist at Mount Sinai South Nassau, and Professor of Medicine at the Icahn School of Medicine at Mount Sinai. He is NYACP District President for Nassau West and is a Master of the College. Dr. Glatt is a spokesperson for the Infectious Diseases Society of America and was the recipient of a CDC's Center for Global Health's Excellence in Partnership Award for helping to make the Rosh Hashanah pilgrimage to Uman as safe as possible. Board certified in internal medicine and infectious diseases, Dr. Glatt is a sought-after international lecturer, author of several hundred scientific journal articles, book chapters, and presentations, including the book Visiting the Sick. And now, Dr. Glatt.
Thank you very much. I want to thank the New York ACP for putting forward this type of a lecture. I think the ACP is just a wonderful organization. I'm so proud to be a part of the ACP, a small part. It's such a wonderful organization for physicians, for internists, and all the subspecialties of internal medicine. And I thank them for putting together this program. So what we're trying to do in the next half hour, 35 minutes, is really update people on COVID. As hard as it is to believe, it is now 4 years since this virus has been in our lexicon. It's gone through several iterations in terms of what we should call it. This novel coronavirus, as we originally called it back in December of 2019, first appeared in Wuhan in China and has, unfortunately, as we all very well know, spread globally. There's not a single place in the world that COVID has not reared its ugly head and caused tremendous loss of life, has caused tremendous impact on the economy, on everything on this planet. And we have to look back in 4 years and think how far we've come. At the same time, while we remember, unfortunately, all of the people that have been lost to COVID, including many physicians and healthcare workers. And we really need to think back upon how the healthcare field are truly heroes and that they face this unknown virus, putting their lives literally on the line and at risk. Healthcare workers from every branch of healthcare put their lives on the line to go and save other people's lives, which is such a beautiful thing and something that we have to acknowledge and remember, all those healthcare workers that did give their lives to help us treat and understand how to manage patients with COVID-19. And we certainly are in an unbelievably better place in December of 2023 when I'm giving this lecture than we were in December of 2019. I remember giving grand rounds at our hospital in January of 2020, talking about this as of yet not in the United States virus that we had some very preliminary information on from sources in China, had published some very limited information, and we were beginning to recognize, or having certainly no real understanding of what this would mean to the world, the potential seriousness of this virus. And just to review, I don't think anybody really listening to this talk needs a thorough review, but just to understand that the mortality in elderly people in the 2020 year was roughly 1 in 3 people. That's mortality. And when I define elderly here, we'll say people above the age of 75. 1 in 3, 1 in 4 of those people who contracted COVID died. Today, thank God, even though there's still many, many people in the United States dying of COVID, estimate there may be 1,000 people a day still in the United States dying of COVID. That's a tremendous number, but it pales in comparison to what was occurring in hospitals and across the United States, across the world in 2019, really 2020, but beginning from 2019 December. And the reasons why we've seen such reductions in mortality and morbidity is because of numerous factors. Number one has to be vaccination. And number two, a close number two, is natural immunity. We have a double-pronged protection with both the vaccines, the different types of vaccines that have come out, and natural immunity for people that did get COVID and survived. So that's a very strong protection. And that works not only against the strains that they initially did get infected with, but it does give you some benefit against future strains. And we've gone from the original strains going through various progressions of mutations to the current strains that we have right now. They're all related to each other. Obviously, some of the medications, some of the immunoclonal antibodies that we gave, monoclonal antibodies that we gave to treat them are no longer effective. But the understanding of the progression of those viruses has allowed us to come up with new treatments, both of the monoclonal antibody category, as well as of actual antiviral agents that we'll talk a little bit more about. But the role of vaccination cannot be minimized in terms of stemming, albeit not stopping. I think the biggest mistake from a PR point of view was people thought that the vaccines would eliminate COVID. What the vaccines did extremely successfully is eliminate a lot of the mortality from COVID, but they did not really totally in any way stop the spread of COVID. While they're effective somewhat in preventing the spread of COVID by reducing infectivity, by reducing people getting COVID, they certainly aren't perfect. And that remains one of the challenges with vaccination, at least the currently administered vaccines, is that they really don't adequately prevent people from getting mild illness from COVID, which then is potentially transmissible still to other people. And if those other people are at higher risk, so then the significant morbidity and mortality that we still see with COVID will occur. Who is really getting sick today from COVID? So people who are younger and healthier almost always will not die from COVID nowadays. Now, they always were somewhat better protected than people who are older and people with underlying morbidity and mortalities, comorbidities. But the bottom line is that even younger people did die from COVID. Even healthy younger people did die from COVID, including children, including infants, including teenagers, albeit far, far lower rates of mortality than in the older populations. And as you go up each decade of life, you're starting to introduce more and more morbidity and more mortality. So that's something important to realize, that nowadays it is extremely unusual for a healthy young person to get significant mortality, morbidity and mortality from COVID-19. So that's a very big positive. Number two, even people at higher risk, people with underlying comorbid conditions and getting on in age, but not at the extreme ends of life. So the risk of serious illness and, heaven forbid, death is significantly lower, especially if they've been vaccinated and or have had COVID. And the combination of being vaccinated and having COVID is something that provides a very strong protection against serious illness and death. So that's very important. The people that are still, unfortunately, potentially at the greatest risk today are those that are at the extreme ends of life, and usually as you get older in life, there usually are comorbidities associated with them. So an 85-year-old who has underlying comorbid conditions, even if they're vaccinated and even if they've had COVID, is going to be at higher risk than their children or their grandchildren. So that's something that's very important for us to realize. And a lot of the efforts in terms of prevention, a lot of the efforts in terms of taking precautions, a lot of the efforts in taking medications should be focused on the highest risk groups. And certainly vaccination should be pushed on the highest risk groups, albeit vaccines are beneficial and can be protective along all ages of life. And we have to understand that the only thing that we really have good data on sometimes are mortality, because that's a pretty yes or no type of an answer. Morbidity, it's hard sometimes to say, did the person have mild, moderate, or severe disease? So yes, you can use certain parameters, such as did they need hospitalization? Did they need oxygen? Did they require ventilatory support? So those are some objective parameters that you can use, but that type of information is not always easily available. And therefore, it's very important for us to understand that the benefits of vaccination may sometimes not show up so easily on a mortality picture, because if the mortality likelihood is very low in, let's say, a 45-year-old person who has one or two underlying conditions, maybe has a BMI of 32, so the likelihood of them having mortality is pretty low nowadays. But at the same time, the benefit of these vaccines and or treatments may be that they don't get very, very sick. So even though it may be difficult to show statistically that the mortality has been changed, because the mortality is pretty low even in the non-treatment group, the non-vaccinated group, nevertheless, there could be significant benefits that are in terms of preventing illness, as well, severe illness, as well as potentially preventing long COVID. Long COVID is something that I'm not going to speak a lot about today, but it's something that we really do not know a lot about. And anybody that tells you that they understand long COVID, that they're not telling you the truth. We really do not have a good handle. 4 years into this epidemic, we don't have a good handle on who is likely to get long COVID, how long will it last, is there a good effective treatment for it? The answer to all of these questions remains we don't know. There are a lot of guesses out there. There is a lot more information on how it works from a physiological point of view. What are the mechanisms behind some of this? But the ultimate answer is we really don't know. That's why I'm not going to spend a lot of time in this talk about long COVID, because it would be really a lot of guesswork and a lot of conjecture without really hard science to support it. I'm hopeful that in the upcoming years, as we begin to really understand long COVID, we may be able to come up with better therapies and ways to prevent it. But let's talk right now, besides vaccination, about how important it is still to prevent getting COVID. COVID is not an illness that you want to get. Even if you're going to, thank God, have mild illness from it, it still is something that is contagious. The people around you are highly likely to get it. If you're living in the same household, different studies show different rates of transmission, depends on a lot of factors. And certainly if there are people in your household that fall into the higher risk groups, elderly parents or grandparents that live with you, people who had transplants, people who are taking significant immunosuppressive therapy, people who have significant major comorbidities. So all of these people will not benefit from being exposed to you if you have COVID. So nobody should want to get COVID. Obviously, people are at risk. Sometimes they've been exposed to COVID. Doesn't mean that they have to quarantine and isolate like we've done in the past, but one should be very much aware. If let's say you're in a work situation. I was just asked this question this morning. Somebody was in a work situation. They were just told that the person that they were sitting next to in their office did come down with COVID, and they clearly were exposed sitting next to them in a closed indoor office for significant periods of time. So what should that person do? So it depends on a lot of factors. Certainly, the likelihood of them getting COVID in the immediate coming days is significant. It's impossible to put a number on that, and we don't have great testing capabilities to know when somebody actually is the earliest part of their contagiousness. And while testing is a benefit in that group, we don't recommend now what we might have recommended then is that person should be in quarantine or in isolation. But we do recommend that they be aware if they become symptomatic, they really need to make sure that they isolate themselves. They should consider wearing a mask if they're around other people who would especially be especially prone to getting severe illness with COVID. And therefore, those types of considerations need to be individualized as to what you should do if you've been exposed to COVID. But let's leave that aside for right now. And let's talk about what happens when a person does get COVID early on. If a person does get COVID, what should they do? So I think the single most important thing that we need to understand in December of 2023 is that the care is individualized. At the beginning of the epidemic, so I think most people have to go with the approach that we really don't know, and therefore one size fit all. And what we recommended many of the times was the same for all people of all ages, of all sizes, and of all different underlying medical conditions, because we really didn't know. And because we had to be especially careful, because very few people had immunity initially, there was no vaccine initially, and you're really talking about a disease that had a very high morbidity and mortality, even across younger age groups, certainly morbidity and even mortality. And as you got older, as I've been saying, the mortality increased. So that approach of we have to do everything for everybody is no longer the appropriate approach. And I think that we need to individualize. And the single most important take-home message from my talk today is that the management of everything related to COVID now should be individualized. It should be nuanced. It should be particular to that individual patient and that individual setting, and not blanket types of public health policies that we have to use initially. So the first thing to do with somebody who has new onset COVID is to assess what is their risk. of progressing to much more severe illness. If they have no real likelihood or expectation that they're going to progress to having more serious illness. In other words, they're a younger person. They have no significant underlying immunosuppression or comorbid conditions. In that situation, I think watchful management, while the patient is isolated, they still should be isolated. They shouldn't be going out into public, certainly not in indoor areas. I think going outdoors is fine. Try not to get too close to people, but outdoors, we really do not see significant transmission of COVID in an outdoor setting. So unless you're on top of people in an outdoor setting, I wouldn't restrict people who have COVID from being in an outdoor type of a setting, although I wouldn't want them near someone else. But certainly, taking a walk outdoors, certainly I think is fine. But in an indoor setting, especially in a poorly ventilated area, they are going to potentially transmit to other people. So I do think they need to isolate. And exactly how much risk family members wish to take or not, that's probably an individual decision. If a spouse who's been with them for the last 3 days and now they're fully diagnosed as COVID, has been exposed to him for the last 3 days, so then I'm not sure that continued isolation is going to be much benefit. They either have been exposed and got it, or they have fortunately not been exposed in a way that's going to cause them to get illness, or they're somehow immune and they're not going to get illness. So those are individual decisions. If the spouse or the other people living in the house are of a higher risk, then it may make sense for them to isolate at that point, even in their own house. But the bottom line is, in terms of a physician managing such a patient, is I don't think that anything needs to be done other than watching that patient, checking, does the patient have any symptoms of progression? Is the patient having shortness of breath? Does the patient have any other symptoms that suggest that they're getting more serious illness? Or if they just have a persistent cough, they have a runny nose, they have upper respiratory infection symptoms. So then if they're, again, in a low risk situation for progression to more serious illness, no therapy should be given. There is no indication to give them steroids. Official CDC recommendations are not to use steroids in that setting because they don't require oxygen supplementation. So then there is no evidence that giving steroids is a benefit in preventing some of the more serious complications. And certainly the indiscriminate use of steroids is associated with all sorts of problems. So it's actually a recommendation not to give dexamethasone as opposed to no recommendation at all. So if a person falls into a higher risk category, so then I would watch them more closely. I would probably want to get oxygen saturation levels on them easily once a day, maybe more frequently. Certainly close telephone follow-up. Are you having progression of any symptoms that is of concern? And that would be for the moderate level risk of progression, somebody who really isn't towards the significant upper range of age. So let's say you're talking about a 50 or a 60-year-old who doesn't have significant comorbidities, doesn't have immunosuppressive medications or conditions. So then in that patient, I would also just watch them. I might watch them a little bit more closely, make sure maybe that they just telephone in every day, every other day to make sure that you feel comfortable as their physician that they're not progressing. And then I would not treat them with anything. Again, certainly not using steroids in that situation. I do not think that the administration of Paxlovid would be of any benefit in that type of a patient because the studies do not really show in the people under the age of 60 who don't have significant illness, significant comorbidities, significant immunosuppression, that Paxlovid really provides any significant mortality benefit in that group. Now, again, that group has a very low mortality, so it may just be that we haven't studied it in large enough numbers, but therefore giving them a medication like Paxlovid, I don't think is necessary if they're under the age of 60 and they don't have really significant underlying medical conditions. Where you want to start giving out Paxlovid, and I'll talk about Paxlovid in a moment, is in patients that fall into the higher risk category. In other words, they're the type of patients that you're very concerned will develop much more serious illness from COVID-19, including even potentially getting hospitalized, getting intubated, and heaven forbid, dying. So you want to start Paxlovid as soon as you can. I'm using the term Paxlovid. I always like to use the generic names of drugs rather than the brand names. Here, there is no other competitor, so I think we all know that I'm dealing with. And also, nirmatrelvir, ritonavir, which is the two drugs that make up Paxlovid, is a little bit hard to say easily, and Paxlovid just flows off the of the tongue, so therefore we'll call it Paxlovid. It is an important agent. It is the best agent to use to try and prevent serious progression of COVID illness. And it is able to be given to people who fall into the highest risk categories. I would not give it to people usually under the age of 60 unless they had very, very severe immunosuppression. And you should try to start it as soon as possible from the onset of symptoms. Now, sometimes the initial symptoms, the testing may be negative. And the question always arises, well, if you really think that it's COVID, even though they have a negative antigen test, it might be reasonable to start Paxlovid, not to prevent getting COVID, but because you really do believe that this is COVID illness. For example, let's say one spouse had it, then the next spouse is starting to have symptoms. The other spouse is starting to have symptoms, and they do an antigen test and it's still negative. So if you really think that you're dealing with COVID, it could theoretically make sense to start the Paxlovid at that point in time. Usually we do wait until a test is positive, and then we would start Paxlovid. And you're not giving Paxlovid to prevent COVID. You're giving Paxlovid to people with early COVID. And you give them this combination drug, nirmatrelvir and ritonavir. The ritonavir, for those that are familiar with HIV, is a boosting agent. It was originally an antiretroviral agent itself, just not a very useful one, but it is very useful in boosting the levels of the drug that it's given with, and therefore it allows you to give the potent drug less frequently and at a lower dose. So therefore, hopefully you have less toxicity and it's easier to go and take it. So we do recommend starting treatment in as early as possible, usually within 5 days of symptoms. So we don't usually give it beyond that. And there are New England Journal of Medicine articles showing the efficacy in these high-risk, non-hospitalized patients. And it certainly is I think, a very reasonable drug to give to people, again, above the age of 60 who fall into higher risk groups, and possibly the people below the age of 60 who fall into significant high risk groups. It is a safe drug, but it has many, many drug interactions. And therefore, it is critically important that a physician prescribing Paxlovid be familiar with all the different drug interactions that can occur. There are many easily available apps online. There's one, I don't own any stock in it, I don't get any benefit from mentioning it, the Liverpool app, that can very easily put in Paxlovid as a drug that they would be taking and put on the other drugs that they're taking. And you can see very well whether there's any drug-drug interactions you need to be concerned about. There are some commonly used drugs that do have interactions, but fortunately, some of the commonly used drugs can easily be stopped. For most people, stopping a statin for 10 days is not going to dramatically impact their risks of why they're on the statin in the first place. So there can be interactions between Paxlovid and statins, but the usual thing to do is to just stop the statin if there's no contraindication to do that, which usually is not. Likewise, a drug like tamsulosin, Flomax, there are potential interactions, and one can either cut the dose or just tell the patient, just be aware that there may be some more symptoms like orthostatic hypotension, for example. So just be very careful when you're getting up, when you are going to have that potential for risk. So some people will empirically decrease the dose. If they're on a double dose of tamsulosin, for example, they may empirically lower it to 0.4 instead of the 0.8 that they're getting. Others will just say, just be aware of it, and just, be aware that there could be some potentiation of some of these side effects. For some of the other drugs, there are absolute contraindications. And if you can't use Paxlovid, so then you're really somewhat more limited in things that you can do. Because unfortunately, the only other really acceptable agent to use that really has strong evidence behind it is an intravenous drug, remdesivir. So remdesivir needs to be given in this situation for 3 days to prevent progression. You're not using it here for treatment, really. You're using it to prevent progression. And since these patients are almost always outpatients that we're talking about, you're catching them early in their illness where they don't meet any criteria for hospitalization. So Paxlovid is very easy to give, but remdesivir, it's much more difficult. There are institutions and agencies that you can give outpatient IV remdesivir 3 days in a row, but it's not as easy to give, obviously, as writing a prescription. So remdesivir is a probably equally good choice in terms of preventing the morbidity and mortality that can occur in these high-risk patients. But I would reserve remdesivir for people that cannot take Paxlovid, have an absolute contraindication to take Paxlovid, and you are able to get them the intravenous therapy for 3 days in a row. I would stress that once they're hospitalized because of their illness, because of COVID, so then we normally do not give Paxlovid. It no longer will be effective. It probably is too late into the course of their therapy. And in that situation, we would use remdesivir, but remdesivir there is being used as a treatment agent rather than something to prevent them from getting more serious infection. And then the duration of therapy for remdesivir will be 5 days rather than 3 days. And then frequently, you'd also consider using it with other agents, again, depending on how sick they were and whether those other agents would be something like dexamethasone, whether it would be something like tocilizumab, or whether it would be something like one of the JAK inhibitors. So all of these are potential additional agents that you can consider using even in combination. And these are important agents for specialists to be using, people that are very familiar with the combination of these agents, using something like dexamethasone, for example, along with either tocilizumab or baricitinib. So you would want to use these agents possibly in combination, possibly sometimes just steroids alone, and those usually would be in much more sicker, hospitalized patients who are requiring oxygen support, and those usually should be referred to an expert in the care of patients with severe and more serious COVID infection. There is one other agent that can be considered, although we really don't use it too much, for the prevention of patients at high risk for progressing to more serious illness with COVID when you're catching them earlier on, and that's an agent called molnupiravir. Now, the data for molnupiravir is inferior to both the data for Paxlovid and for remdesivir. And I would only consider using molnupiravir in situations where I absolutely could not use either Paxlovid or remdesivir, and this patient was at very high risk for progression to more severe COVID-19 infection. And right now they're okay. They don't need hospitalization. They wouldn't benefit from steroids. They should not get steroids. And you really have nothing else that you can offer them. So then there are limited data to suggest that molnupiravir might be effective in that situation. The important thing to remember about molnupiravir is that it can't be given in women who are pregnant or nursing. So again, those are important considerations, but usually not the highest risk group of patients. If they're pregnant or nursing, they probably usually aren't in the highest risk groups. And therefore, I would not recommend using molnupiravir in those categories anyway. So in the 60, 65, 70 plus age group who have significant risk of progression because of underlying other problems and cannot take Paxlovid or remdesivir for whatever the reason, you can't get it, they can't take it, so then I would consider using molnupiravir in that setting. Finally, in patients who are hospitalized and are not doing well, so then there are some other options that can be considered, that need to be considered in terms of whether you want to also give them anticoagulant therapy, should they get therapeutic doses of heparin, or should they be getting prophylactic doses of heparin, or should they be getting other agents using potentially intubation, using high flow oxygen, using other forms of non-invasive ventilation, BiPAP. These are all, again, people expert in the management of such patients should be involved, consulting on and helping to take care of these patients. This is usually beyond the realm of the typical internist, unless they happen to be someone who has really seen a tremendous amount of COVID infection. And during the height of COVID, almost every internist, hospitalist practicing in a hospital would feel very comfortable with these types of therapies as they were routinely used. On our busiest day here at our hospital in Mount Sinai, South Nassau, we had over 400 COVID patients, most of them quite sick, on the highest census day that we had. So we basically were operating, probably a quarter of those patients were equivalent of an ICU type of a care. And unfortunately, the seriousness of that day is embedded in my mind, how difficult it was to manage so many patients with such severe illness. And we really thank God that we're no longer in that situation right now. Finally, the last thing that I wanted to speak about before we take some questions is what can we do furthermore to prevent COVID. So again, I talked already a little bit about vaccination, the importance of vaccination. There are many different agents that can be given. There are different vaccines available to prevent illness, and each person really should assess what is their personal need to get vaccinated. People who then have been fully vaccinated in the past have had COVID and don't fall into these higher risk groups may or may not really need the new boosters that are now available. But for most patients that have not recently been vaccinated, and at this point in time, unless you've gotten the newer booster vaccines, I would say that you're not considered to have been boosted with the recent time. So then if they fall into any of these risk groups for progression, so those are the people that I would recommend getting vaccinated. As a very strong push to get them vaccinated. And for those that really don't fall into those categories, have had vaccinations in the past, albeit not with the newest vaccine, but especially if they've had COVID and they don't fall into a situation where they themselves are at risk or the people around them are high risk. So then I think the individual decision to vaccinate should be just that, a decision between the patient and their physician as to whether or not they should get vaccinated. I think there's nothing wrong if they get vaccinated, but that would not be the type of patient that I would spend a tremendous amount of time and effort on to make sure that they got vaccinated. So we've gone about a half an hour right now. We've talked about the most important treatment options that we have. And I'll just conclude with some last things about other treatments. So there's a lot of things that are being looked at and tried for COVID, and whether we'll eventually see any of them having real benefit or not remains to be determined. But there are many both homeopathic regimens and remedies out there, as well as some FDA-approved medications, but not for the COVID indication, that people have been trying to treat patients with COVID with. And all I'll say at this point in time is that there is no convincing evidence that the usage of any of those treatments, such as using fluvoxamine, which has been recommended by some people, and now studies have shown that it really doesn't provide any significant benefit. Certainly the ivermectin story has been a very long story about its benefits or a lack of benefit. And I think clearly the studies at this point show that there really is no benefit from giving ivermectin. And any other agents that people have tried to use in the hopes that they would be a benefit, there at this point in time are really no good evidence to suggest that any of these should be given routinely outside of a study setting. So on that note, I'll turn it back to Lisa from the New York ACP, Lisa Noel. And I thank you so much for giving me the opportunity to talk about COVID, and we'll take some questions.
Thank you so much, Dr. Glatt. This was really an informative presentation as someone who just got over COVID a couple weeks ago. So I appreciate your insight. We did receive several questions from our Quality and Patient Safety Task Force. And in looking at them, you have touched on some, but I'll just read them, a few of them. So regarding treatment options for hospitalized patients, when you're looking at asymptomatic COVID patients and symptomatic COVID patients, when do you use steroids or don't you?
So that's a great question. So the usage of steroids is contraindicated before you get to the hospital. In the hospital, we don't recommend the usage of steroids. Also, it's contraindicated if you don't require oxygen supplementation. And at what point you require oxygen supplementation, we usually use a cutoff of somewhere in the low 90s, maybe up to 94%. So if your oxygen saturation is above 94%, we do not recommend steroids. We say do not use steroids. On the other hand, when they do require supplemental oxygen, so let's say for argument's sake, their O2 sat is 91. So in that situation, if they're hospitalized because of COVID, so then we would recommend that you use dexamethasone. In many of those patients, we would also recommend that they get, in addition, either remdesivir, or if you can't use remdesivir, then you could use just dexamethasone alone, or you could add to it either baricitinib or tocilizumab. So those would be options as well. But normally the go-to agents in that situation would be remdesivir if they just required minimal oxygen, and consider using dexamethasone as well in that situation. And then for patients that are having much more significant oxygen demand, then we would consider adding an additional agent.
Thank you. Another question, can I use Paxlovid for hospitalized patients?
Okay, that's also something that comes up all the time. So the answer is no if they're hospitalized for COVID. If a patient has unfortunately not been recognized and not been offered Paxlovid early in the course of therapy, Paxlovid doesn't really work probably more than 5, maybe up to 7 days into the course of illness. And normally patients don't require hospitalization in those first week of symptoms. It usually progresses if it's going to progress to the point, let's say day 8, day 9, day 10, day 12, they require hospitalization because of oxygen usually demands. In that situation, Paxlovid doesn't work. The one situation where we would consider giving Paxlovid in a hospitalized patient is if they're hospitalized for something else. So let's say somebody was exposed on Monday to a patient with COVID, and in fact is going to come down with COVID, but they're not going to really become symptomatic from COVID until, let's say, Thursday, Friday, or Saturday. But Wednesday, they get appendicitis, and they come into the hospital on Wednesday, they have appendicitis, and all of a sudden, now they're in the hospital, and they're starting to manifest early onset COVID. So that's not a hospitalized patient for COVID. That's a patient who happens to be hospitalized for another reason and has COVID. And in that situation, Paxlovid in a hospitalized patient is appropriate. Again, I would only give it to those at very high risk, those, again, in the group above 60 years of age, with the more underlying comorbid conditions, the more likely I would want to give the Paxlovid. But that's different than a hospitalized patient because of COVID. This happens to be a patient who is hospitalized for another reason other than COVID, who's at high risk of progressing to severe COVID. That's when you would give Paxlovid to a hospitalized patient.
Thank you. Next, are health systems still screening for COVID prior to hospitalization?
So that obviously is going to depend on the health system. But I would dare say in my area, and we have regular monthly meetings amongst all of the systems, what's one of the really, really nice things about COVID is the unbelievable camaraderie within the infectious disease community to share information, to share best practices, and systems that might otherwise normally, quote, be competing for patients. Here we're sharing information on a regular basis, talking about what we're doing, what are you doing, and coming up with best practices that we can all incorporate. So in my area, I think none of the systems are routinely checking patients anymore for COVID, whereas they may still have specific testing on very high-risk units. Because let's say you have a transplant unit, or if you have a unit that has very highly significantly immunocompromised patients, so then you wouldn't want to introduce into that group somebody that may be relatively asymptomatic or totally asymptomatic who has COVID. That could unfortunately be a terrible, terrible problem in that group. But in general, for hospitalized patients, before they go through procedures, before they enter the hospital for non-respiratory, non-COVID potential illness, so that I think most places are not testing right now. There may be some across the country that still do, and there's certainly value in that, but at the same time, you have to figure on the cost-benefit ratio. Is that something that is sustainable, doable, and necessary?
Thank you. Is rebound causally related to Paxlovid or a random occurrence?
So it's interesting. When it was first noted, this rebound phenomenon, it was often in patients who had recently been given Paxlovid, and some well-known famous people in the field of medicine were some of the first people to write this up on their own personal situation. However, if you go back and look at the studies, so the phenomenon of rebound was present prior to the usage of Paxlovid. And if you look at the original studies on the natural normal history of COVID-19, there is this biphasic, bimodal type of a course in a significant number of patients. So my own personal feeling is that Paxlovid may slightly increase that possibility of having this rebound, but rebound is certainly something that is a part of COVID and is not specifically only related to Paxlovid.
Thank you. And one last question. How can we best advise our patients in developing habits to prevent the spread of COVID between family members?
No, so that's a great way to close this talk off with, because we're not diagnosing COVID as much. People aren't getting tested as much. People don't want to get tested as much. So the underlying principle of life in dealing with respiratory illnesses is if you have a respiratory illness, it undoubtedly, these viral illnesses, whatever the source is, whether it's flu, RSV, COVID, an adenovirus, a metapneumovirus, or any one of the hundreds of other viruses, including the quote, routine coronaviruses, not the novel coronaviruses, but the routine coronaviruses. So then they're all contagious. Everyone is contagious. They have different public health implications, but they're all contagious. And the rule of thumb should be is if you have a contagious respiratory illness, stay away from other people. As indispensable as every one of us thinks we are, somehow when we go on vacation, they manage without us. When we take off time to be with our friends and family for holidays, they somehow manage without us. So they will somehow manage without you, rather than you getting everybody else in the office, everybody else in the waiting room, everybody else in the suite that you work sick. If you have a respiratory illness that is presumptively due to a contagious virus, stay home, stay away from other people, isolate yourself to the best possible extent, and that will be the best way to prevent the spread, not only of COVID, but of all these illnesses. The one thing that we did see very positive from COVID was that when we did mask and isolate from COVID, the incidence of influenza and RSV essentially fell to zero. So as you're not being exposed to these viruses, you're not going to catch them. Now, we're not going back, and nobody wants to go back to that drastic level of isolation. But at the same time, the people that are sick should try to isolate themselves as best as possible from other people so they don't spread respiratory illnesses.
Thank you so much, Dr. Glatt.